Good afternoon, everyone. My name is Kirby Sinclair, and I'm here with Patricia Ferrito. We'll be watching a pre-recorded session of How Sick is My Cohort of Patients? General Approach to Identify Chronic Conditions. Once the recording completes, Patricia will be answering questions that you submit in the chat window. So here we go.
Hi, everyone. Thank you so much for attending my presentation. I will be presenting a package that answers the question, how sick is my cohort of patients? A general approach to identify chronic conditions. As a brief introduction, I'm a senior research programmer at the Leonard D. Schaefer Center for Health Policy and Economics. The Schaefer Center is a premier research center for evidence-based health research at the University of Southern California. We often work with large data sets, which means that we need tools like SAS to expertly manage and analyze our data. I had my very first coding experience with SAS, and I just fell in love with data analysis and programming. 6 years later, I've been given the opportunity to publish my SAS work in 3 papers on dementia care and treatment. I've been very grateful to work on this project with 2 wonderful colleagues, Laura Gasquet and Patty St. Clair. Patty is a senior data advisor at the Schaefer Center, and Laura is our claims analytics lead. Between the 2 of them, they have published a breadth of research on the impact of health policy on outcomes and economic costs. We are very excited to be sharing with you today a package that has been helpful for our colleagues at the center and we hope will be helpful for you. So why is it important to have a package for identifying chronic conditions? Well, for one, we live in an exciting time where the volume of data is growing exponentially. The healthcare sector specifically has the largest and fastest growing data with a 48% annual growth rate. The chart on your right shows that in 2013, we had about 150 exabytes of healthcare data, which was projected to grow to 2,300 exabytes in 2020. This ever-growing volume of data requires validated and standardized methods of analysis, which is exactly what our package provides. We are also living in the middle of a global pandemic. Imagine that with this data, you could identify which patients were more likely to get a COVID diagnosis. Our package brings us closer to that reality because with it, you could identify which patients had a history of respiratory disease or heart conditions. You could then calculate which combinations of conditions were more likely to lead to a COVID diagnosis down the road. This information could be used to improve preventative treatment or specialized healthcare. So what are the key factors for successful identification of chronic conditions? Rarely is it ever as simple as a patient visits a doctor and gets a diagnosis. There's often testing that needs to be done. There are often false diagnoses that later need to be corrected. Time frame matters, and also where a patient gets diagnosed matters. For that reason, standardization is really important to take these factors into account. Standardization is also important because it allows for comparison of results across studies, across populations, and across timeframes. For example, let's say that 5 papers were published on the demographic characteristics of the diabetic population. Even with the same data source, these papers could have widely different results if they use a different definition of diabetes. This is where standardization is really key. However, validation must accompany standardization. A standardized definition is only as good as its performance. We implement validated algorithms published by the Centers for Medicare and Medicaid Services. The CMS has published papers on how they arrived at each algorithm, most of them comparing self-reported rates to the rates found in claims diagnoses. Researchers everywhere have used these algorithms in their work to identify their study populations. However, the strength of our package lies in its flexibility. No 2 data sources or research questions are built alike. An algorithm might require that a reference period be 3 years. However, a researcher only has 2 years of data to work with. Rather than prevent progress, our package allows for the customization of each algorithm according to research needs and resource limitations. As a brief overview, we identify the presence of 27 common chronic conditions, which I'll be showing on the next slide. As I already mentioned, we implement validated algorithms from the CMS Chronic Conditions Warehouse, which I'll refer to from here on out as the CCW. The CCW does not publish its code for the algorithms, so we've replicated them in SAS. However, you can request the data directly from the CMS, and they will provide you data for the Medicare beneficiaries on who has each condition. The chart on the left briefly shows that there are 4 inputs that feed into a main macro, which will then output yearly beneficiary files. So this table here on this slide on the right shows the 27 common conditions that we have algorithms for. It includes conditions such as hypertension, hyperlipidemia, asthma, Alzheimer's disease, and rheumatoid arthritis. The CCW also publishes 40 other chronic conditions that are mainly for mental health issues. These include conditions such as schizophrenia, bipolar disorder, and substance use disorder. While these conditions are not included in our package, they can be easily added in using our customizable features. All of this information is published in detail on the CCW website. I would encourage researchers to keep in mind that the CCW often updates their definitions and adds diagnoses and conditions to the list. For this reason, it's important to keep track of the updates they post on their website. So what does the algorithm take into account? There are four main components to the algorithm. First are the qualifying ICD-9, 10, and ICD-9 diagnosis codes. For those of you unfamiliar with the ICD, it stands for the International Classification of Diseases 9th and 10th versions. The 10th version was implemented in October of 2015. These are the codes that physicians will use to identify which diagnoses were given to a patient at a certain claim. In addition to the qualifying codes, it also matters the order in which the code was given. For example, the algorithm for cataracts requires that the diagnosis be the primary diagnosis on a claim. This means that if a patient was first coded for diabetes and second coded for a cataract, this claim does not qualify, as the cataract claim is not the primary diagnosis of the claim. Second, the algorithm will take into account claim type and the number of each claim type required. There are four various types that the algorithm identifies by default: inpatient, skilled nursing facility, home health agency, outpatient, and carrier claims. It will then specify the number of each of these types required. This will depend on the condition, as some conditions are more likely to be seen at an outpatient visit, while some conditions are more likely to be seen at a hospital stay. The third component is the reference period. This is the time period in which the algorithm will look for a qualifying claim. For most conditions in the CCW, the reference period is 1 to 2 years. However, some conditions have a reference period of 3 years. This also depends on the condition. For example, a short-term condition such as a heart attack will likely only have a reference period of 1 year, while an ongoing condition such as Alzheimer's disease will have a reference period of 3 years. This is because you would most likely see that a person diagnosed for Alzheimer's 3 years ago will likely have the condition today. The fourth component is enrollment. The package will check that each patient has enrollment for the whole reference period. This is because if they weren't enrolled, you might not be able to see all of their claims on a particular year. This is important because if you include those beneficiaries, you might be underreporting your incidence and prevalence rates. So if you request the data from Medicare, they will give you a first ever date, which is the first date that they find a qualifying claim, a mid-year flag, which looks from July 1st to June 30th of the reference period, and an end-of-year flag, which looks from January 1st to December 31st of the reference period. Our package also produces a first flag, first ever date. However, instead of a mid-year and end-year flag, we produce monthly flags. These monthly flags are very useful for looking at a specific time frame. For example, in pharmaceutical research, you often need to look at an index date or a first ever drug use. You might want to see what diagnoses were given before or shortly after this drug use. In this case, the monthly flags are much more useful than a mid-year or end-year flag. All of these flags have 4 potential values, with 0 and 1 being values for beneficiaries that were not enrolled in the full reference period. Values 2 and 3 are for beneficiaries that had enrollment for the whole reference period. A value of 0 or 2 means they did not have qualifying claims, and a value of 1 or 3 means that they did have qualifying claims. This is an example of one of the published algorithms from the CCW for Alzheimer's disease and related dementias. You'll see that it has a reference period of 3 years, which means that for an outcome year of 2020, the mid-year flag looks from July 1st of 2017 through June 30th of 2020, and the end-of-year flag looks from January 1st of 2018 through December 31st of 2020. You'll also see all of the valid ICD-9 and ICD-10 codes. In parentheses, it notes that any DX on the claim counts. This means that there's no requirement that it be a primary or secondary diagnosis on the claim. Finally, on the far right, it shows you all of the valid claim types and the number of each required. There's only one of any of the 5 required in order to count. So now that we've gone through the algorithm components, how do you run the package? The first thing that you want to do is decide whether or not you want to customize the package or use the default. If you want to use the default algorithm rules, then you simply have to leave the package as is and it will run the built-in algorithm rules. However, if you want to customize it according to your research question, we've provided Excel sheets that will easily let you define the algorithm according to your research question. The first Excel sheet shows a snapshot at the top, shows all of the algorithm rules for each of the conditions. Conditions can be easily removed or added to this list. Any of the cells can be customized according to the algorithm definition you want to use. For example, you can change the claim types or the number of claim types required. You can also change the reference period, which is shown here in months. You can also change the minimum days apart required between two qualifying claims. By default, we require that at least 1 day apart be found between two claims. This means that two claims found on the same day do not count. You can also apply a maximum days apart requirement. This means that if you want to see two claims in the same week, you can add a 7-day maximum requirement. A separate Excel cell sheet lists all of the valid ICD-9 and ICD-10 codes for each condition. This can easily be customizable by adding or removing diagnosis codes from the list. At this snapshot, you'll see there are 4 ICD-10 codes for Alzheimer's disease and 1 ICD-9 code for Alzheimer's disease. For example, let's say you're only interested in early onset Alzheimer's, you'll probably want to limit to code G30.0, which is for early onset Alzheimer's in the ICD-10 definition. However, it's important to note that there is only one code for ICD-9 and it does not differentiate between early and late onset Alzheimer's disease. In this case, if you're working with longitudinal data, you'll want to make sure that your definitions are the same across years. After you've decided whether or not you want to customize your algorithm, the next step is to process your claims input data. The package will accept any administrative health records with the following information: a unique patient identifier, a validated claim date, the diagnosis codes on the claim, the order of the diagnosis code, and the location or the claim type. Most administrative healthcare records have this information, although it may not look exactly as it does for the Medicare data. In this case, you might need to do some tweaking. For example, in Optum, which is a private healthcare data source, they have additional locations for emergency room care and ambulatory care. These could be grouped within inpatient, or you can create separate claim types to categorize these locations. After you've processed your claims input, you will then need to process your enrollment data. This is to help you identify whether or not enrollees were covered in the whole period. The package takes 2 separate inputs for the enrollment file: a period file, which has a beneficiary and a start and end date for when they were enrolled, and a monthly file, which has a flag for whether or not a beneficiary was enrolled in that month. Finally, after you've processed both your input and enrollment data, you'll want to feed your macro variables into the package and define them in SAS. These are only a few of the macro variables. The rest are listed in detail in the package documentation. However, you'll want to specify what is the patient variable, what are the input data sets. You'll also want to specify the minimum and maximum outcome years. Now keep in mind that if you have an outcome year, you'll also want to include all of the years of the reference period. So if your outcome year is 2020, but you have a condition with a 3-year reference period, you'll want to include data from 2017 all the way through 2020. There's also then a switch for whether or not you've customized the algorithm, and you can customize which conditions the algorithm will run. So by default, the package will run all 27 conditions. However, if you're only interested in a subset, you can specify that in the macro. So now you've run the macro. There are a few internal processes that the macro will run. Without getting too much into the weeds, first, if you've customized the package, the macro will read in your input files and process them. Otherwise, it will use the built-in definitions already included in the package. Then it will process your enrollment data, and finally, it will process your claims data, looping through each beneficiary and each condition and flagging for qualifying claims in each one. As we've already discussed, the output are yearly files with 1 record per patient, a first ever date, and also keep in mind that this is the first ever date in the years that you've provided into the package. So for example, if you've only provided 3 years, it will only look for a first ever date within those 3 years and not earlier or later. And as I've already mentioned, it produces monthly flags with the values that we've discussed. From there, you can merge this data to any analytical data set or you can use it as is to find incidence or prevalence rates. For incidence and prevalence, you will likely want to limit to values 2 and 3, which are the beneficiaries that were enrolled throughout the entire reference period, just to make sure you're not missing any claims from those beneficiaries that were not enrolled. So how well does our package perform? Well, to validate our package, we ran it in the Medicare data and compared with the data set that Medicare provides. We found that we had about a 99% match rate with our flags and the Medicare flags in both the ICD-9 and ICD-10 periods. We thought that this performance was pretty high, and it shows evidence that our package was able to replicate the Medicare algorithms pretty well. In this table, you'll see for the top most common chronic conditions in the 65 and older population that we have almost 100% match rate in 2014, the ICD-9 period, and 2016, the ICD-10 period. We've already used our package for various projects across the center. One of the ways that we've used the package is to compare prevalence across different populations. Often in medical research, you want to know why certain populations have selected into different healthcare plans. You'll also then want to know how their healthcare utilization differs and how their healthcare services might differ. Looking at prevalence is one of the ways to answer these questions. In this particular chart, we've compared the Optum Medicare Advantage population with the traditional Medicare fee-for-service population. Optum Medicare is a private data source, and the traditional Medicare fee-for-service used the Medicare data source. You'll see here that between these two populations, the traditional fee-for-service population tends to have a higher prevalence in almost all conditions. This is likely due to the fact that younger populations tend to select into the Medicare Advantage groups, which we can see here that they also tend to be healthier. We've also used the package to compare between ICD-9 and ICD-10 coding systems. This is really important for longitudinal data where you want to make sure that your definition is comparable across years. Here you'll see that the prevalence rate for asthma jumps up in the 2015 ICD-10 period. Part of this reason could be that the coding systems are different between ICD-9 and ICD-10. Upon further examination, we also noticed that the definition of asthma changed in the ICD-10 period with the 2017 definition of asthma. However, the CCW has recently changed the definition to exclude the additional codes that were not included in the ICD-9. If we ran this today, we might notice that the prevalence rates are more consistent across years. This last example shows the diabetes prevalence across 3 different customized versions of the algorithm. It shows how easily you can customize the algorithm based on your research needs. For this particular example, we were interested in whether or not diabetes rate changed if we applied a 6-month maximum or a 3-month maximum. The reason we were interested in this is because we consistently saw that self-reported rates of diabetes were much lower than rates found using claims diagnoses. One potential hypothesis for this was that claims were being picked up where people were getting tested for diabetes, but not necessarily had a confirmed diagnosis of diabetes. We wanted to exclude these people by ensuring that claims were only found if they went to a doctor twice within 6 months or twice within 3 months. As you can see on the chart, you do see that prevalence decreases with each strict definition of diabetes, getting us closer and closer to the self-reported rates. You'll also see that there is a striking difference between the ICD-9 period in dark blue and the ICD-10 period in light blue. This could be because of coding differences or because the definition of diabetes has changed between these 2 periods. While this exam requires further exploration, it does show the power of being able to customize and quickly change the algorithm depending on your research needs. We know that there are many more potential uses for our algorithm, which is why we wanted to share our package with you today. We thank you so much for coming to our presentation, and we hope that you feel free to reach out if you have any questions or comments. Thank you, and hope you enjoy the rest of the conference.
That was a great presentation, Patricia. If I could ask, what inspired your team to develop the package?
So thanks so much, Kirby. We actually have multiple people working on different sorts of data. So we have some people working with public Medicare claims and some people working with private claims. And there was an interest in trying to compare prevalence rates and incidence rates of conditions between the two sources of data. And so in order to make those comparisons in the private claims, we needed to replicate these conditions. And so a few of us came together and we came up with this package, replicating the Medicare conditions algorithms for private claims data.
Okay. Do you have any recommendations on pitfalls to avoid when using the package?
Yeah, so one thing for sure to be aware of is to make sure that you're including all years of the reference period for each condition. So it might be a little tricky if you have different years of enrollment data and different years of claims, and also varying reference periods per condition, to keep in mind of what exactly you're interested in. So one of the things to be aware of is that you're putting the maximum reference period years, of feeding the maximum years into the package so that you're giving it all the information that you can. Otherwise, the package will be incomplete as it won't be able to see all of the claims in that reference period.
Okay. That kind of speaks to the, I guess, quality and quantity of the data. Can you comment on, the quality of the incoming CCW data?
Yeah, for sure. So Medicare data generally comes in pretty clean and organized, I would say. It's already come in cleaned up files. The variables are pretty well organized. And, but of course, it's not perfect as any data source is. And we often do checks just to make sure that across years there's consistency across variables such as death date, birth date. We've often found that there are patients that appear like they have been living for over 200 years, and discrepancies between a birth date in one year and a birth date in another year. And so errors like these do occur. However, they only occur about less than around 1% of the time. And so what we'll do to standardize the data is just to flag them and make sure that people know, researchers know that they exist, so that if they're using this data, they can decide what they want to do with some of those inconsistencies. But like I said, for the most part, 1% of the data are the errors like that, and most of it is pretty clean.
Okay. Is it possible to turn off, say, the claim order requirement, given that primary and principal DX is not always captured?
Yes, definitely. That is one of the customizable features. You can change that so that for all of the conditions, you can look at any DX. I know in some data, like you said, they don't have principal or secondary DX. And so you can change it so that any DX is considered on the claim.
Okay. Question from the viewers. Can this package be used, say, to make the CDPS RX more robust? I don't know if that's clear, so perhaps they can maybe elaborate on that question. Sorry, how were the algorithms derived? That's the one question that I had.
Those are both great questions. So unfortunately, I'm not super familiar with the CDPS RX portion. So that would be great if somebody wanted to elaborate on that in the chat. But the algorithms are derived. There's a reference list available on the Chronic Conditions Warehouse website that lists all of the papers that they used and coming up with the algorithm. So for example, there's a paper for the Alzheimer's disease algorithm in which they compared a registry of patients with confirmed Alzheimer's disease and then looked into their claims to see whether or not they would be able to identify Alzheimer's in their claims. And I believe in this paper, they were able to identify around 87% of the confirmed patients with Alzheimer's from the claims data. And from that, they recommended that there be a longer reference period. So that's why you see with Alzheimer's, you have a 3-year reference period, and you also need to look at outpatient as well as hospital claims in order to get the full picture. And so the CCW provides a list of all of these reference papers that they used for the algorithms, and it's pretty interesting to see them.
Right. How many years or period would you use for the prevalence, and how would you define it in the package?
Yeah, so for prevalence, the package has a different reference period for each condition. So as I mentioned, some conditions have a shorter year span for prevalence. So for example, a heart disease or a stroke only has a 1 year look back for prevalence. And so if somebody has that condition prior to those 2 years or prior to that 1 year, they wouldn't be considered, a heart attack, prevalent heart attack. But for something with a longer reference period, say 3 years, anytime within those 3 years they have it, the 3 year period would be the prevalence period. And so it depends on the condition. There are already preset by the algorithms as defined, but they can be customized. So for example, if you think that something needs to have a shorter or longer reference period or prevalence period, you can define that in the macro package itself.
Okay. How do you version the packages or the macros?
Yeah, that's a great question. So we're still in the process of versioning right now. We are currently basing our version of it off of the 2017 definitions of the conditions, which is when we started working on this like 2 years ago. So we're still using that definition, but they have some of the condition definitions have been updated since then. So we plan on GitHub, and there is a GitHub link that I will share in the chat. It's also available with the SAS article. If you look us up on GitHub, the USC Schaefer Center Data Core, we will be posting updated versions of the macro package as we update it and as we make it more, as we look at the new definitions of the conditions, and also as we add more data. We're considering adding in the 40 other chronic conditions, for example. And so this will be a version 2 or a version 3 of the package that we will put online with the GitHub as well.
Yeah, and thanks for bringing that up. I know a couple of people, more than a couple of people have asked about the code, and I'll just remind everybody that it is available on GitHub under the title of the presentation. So we have a confirmation or at least elaboration on the CDPS question. CDPS calculates the risk scores for a cohort of patients given their diagnosis in a hierarchical form. Does the package also calculate risk scores within the cohort?
Okay, that's a great question. So if I'm understanding correctly, the CDPS is sort of similar to the HCC or a Charlson comorbidity score. So this package is different in that it does not calculate a score. It merely flags for the presence of a condition. And so there is no weighting of different conditions or giving conditions a score or taking a total of all of the various conditions and creating a score from it. It's really meant to just give a flag to say the presence of this condition, whether it exists or not. And so that can definitely be used if you're interested in looking at a subset of conditions within the CDPS, for example. This can be used to supplement that and probably not to substitute it completely because there are uses for scores. But as a supplement, it could be useful, I think.
Okay. Do you have some tips maybe for how you would use a package on private claims?
Yeah, so I think one of the main things to be aware of in private claims is that the location type might differ from Medicare. So for example, there might be additional, more detailed location types in the private claims in the way that they're organized. So the way the Medicare files are organized is that they're already broken up into inpatient, outpatient, skilled nursing facility files. However, this might not be the case in a private claim setting where all of the claims, depending on the location type, are in one file. And so the one thing to be aware of there is what your location types are and how you want to organize them. Do you want to organize them in a similar fashion to the Medicare claims, or would you like to redo the organization of location types and customize it to fit your data? And so these are just some things to keep in mind when you're looking into private claims. And also that Medicare claims, these algorithms were built for, it might change depending on the the population. So the demographics of your private claims might be completely different than the demographics that the algorithms were built based on. And so it might be a good idea to look at the reference papers and see, is this a unique population in my private claims that doesn't compare to the algorithm, or how might I want to change the algorithm to better fit my data? So those are good questions to keep in mind when you're applying it to a different claim source.
Okay. That's all the time we have for questions today. And Patricia, thank you very much for joining us and answering questions about your presentation. How sick is my cohort of patients? A general approach to identify chronic conditions.
Thank you so much, Kirby, and thank you all for attending. And please feel free to reach out if you have further questions or comments.
Will do. For our viewers, we hope you will continue to explore all this great content that we have available on the SAS Global Forum users YouTube channel. And please don't forget to take the session survey on the SAS Global Forum Attendee Hub. Have a great day.